Hi everyone. I think let's get started since it's 5:01, and then anyone else who joins will join when they can. I hope that you are all doing well, and welcome to the Merit Education Rounds. This is our first round for 2025. I hope all of you had a great new year. I am Dr. Elif Bilgic, and I'm an education scientist in the Department of Pediatrics and also the McMaster Health Education Research, Innovation, and Theory, or the Merit Center. And so the Merit Center is an education services center in the Faculty of Health Sciences dedicated to advanced health professions education scholarship with a vision to grow a community of scientists and clinicians to advance health professions education through research and applied science. Although today's education rounds is virtual, many of us in this event are connected by the land on which we work. So I take this time to recognize that McMaster University is on the traditional territory shared between the Haudenosaunee Confederacy and the Anishinaabe Nations, which was acknowledged in the Dish with One Spoon Wampum Belt. That wampum uses the symbolism of a dish to represent the territory, and one spoon to represent that the people are to share the resources of the land and only take what they need. Now, before leaving the stage to our esteemed guests, today I will provide a very brief introduction. So the title of today's education round is Models, Modalities, and Modifications, Factors in Influencing Anatomy Learning Difficulty and What We Can Do About It. And we have Dr. Danielle Brewer-Deluce as our speaker. Dr. Brewer-Deluce has a PhD and is an assistant professor in the education program in anatomy, Department of Pathology and Molecular Medicine at McMaster University. She teaches anatomy in both the undergraduate and medical programs and coordinates the anatomy lab at the Waterloo Regional Campus. Dr. Brewer-Deluce is an award-winning education scholar with over a decade of research on assessment, the development of learning adjuncts, equity, diversity, inclusion, and the use of digital technology in anatomy education. With her expertise in mind, the rounds today will focus on exploring what model-based factors influence anatomy learning difficulty, how teaching and testing modalities influence this, and what modifications educators can make. During the rounds, feel free to use the chat for comments and questions, as I will ask those during the Q&A period. Also, during the Q&A, you can ask questions by using the hand raising function as well. So without further ado, please go ahead, Danielle. You are muted.
Awesome. Okay, perfect. All right, thank you so much for that kind introduction. I'm delighted to be here tonight, joining you virtually to go through this talk and take you on the journey of the last sort of 5 years of my research program in this area. So to echo what's already been said, I also wanted to acknowledge that tonight I'm speaking to you from McMaster University, and that it's located on the traditional territories of the Mississauga and Haudenosaunee Nations. And in doing so, I thought a lot about what it means to share this space with you tonight and the privilege associated with that. And so it occurred to me that, this tradition of telling stories, knowledge translation, is not a new one, and is in fact something that's been carried out for generations by people before us and the people are going to come after us. And so I wanted to thank you for sharing the space tonight and partaking in this tradition of storytelling. And I hope that regardless of where you're from or why you came, you leave with some insight as to what we've been working on in anatomy and how that might apply to you. So to get us started here, I wanted to ask you a question. What makes learning difficult? Now, you could take this as a moment to pause and think for yourself about that. You're welcome to respond in the chat if that seems right to you. But I am happy to take a second here, and happy for you to take a second here to think about what it is that makes learning difficult. So I'm seeing a lot of things like steep learning curve and jargon, not knowing if you're doing the right things or not, and sometimes not even knowing where to start. And these are a lot of things that I think about too, when it comes to learning and difficulties that students might encounter with that learning. And, difficulty then comes in a lot of forms. And as educators, we know this, but we also recognize that difficult doesn't always mean bad. In fact, when we consider how learning success looks for students based in difficulty terms of low to high, if that difficulty is low or high, we see lower learning success. And this is either because the material isn't engaging, it isn't causing the student to, pause and recognize its value, or it's too hard. It just seems overwhelmingly difficult and impossible for something for them to grasp. But if we hit the middle part, that desired difficulty, we see a peak in learning success. And desired difficulty is this idea that learning is most effective when it is challenging, but not too difficult. And this sort of sweet spot is what we as educators strive for every time we walk into a classroom. Now, how do we do this? Well, one of the most common techniques we see in education is scaffolding. And by definition, scaffolding is something that others do, others who are in the know, like teachers or teaching assistants, or perhaps even a senior colleague. It's something that others do for a learner to help them progress through appropriately challenging tasks for a temporary period of time. And I want you to think about that for a second. It's temporary in that it helps you for the period of time that you need it, and it is still a challenging event. So what does scaffolding look like in anatomy? Well, for those unfamiliar, anatomy is the study of the human body. And we break anatomy into systems that exist throughout the body, basically based on function. So in this image here, we're depicting the skeletal system, the cardiovascular system, and respiratory system, along with many others leading all the way to the muscular system. And most anatomy courses start here at the skeleton, because it forms a foundation point on which we can attach everything else or literally encase everything else in. And so in anatomy, this type of learning, the learning of bones, is characterized by something called nominal anatomy. And as I just mentioned, it's the concept that we're going to have students learn the names of the grooves, bumps, hollows, and features on a bony structure. And this is a fundamental first concept for learners. It forms that literal skeleton that we build everything else on and around, and it lays groundwork for understanding physiologic and clinical correlates down the line. And in doing so, we make sort of a general assumption. Now, I'm an MSK anatomist, so I'm kind of guilty of this as well. But the way that we usually teach this is we send students into the lab because we think this is an easy enough task for them to accomplish and say, here is a skeleton or plastic models of bones, here is an atlas, and hop to it. And we kind of leave them to their own devices in a major regard to learn this because this is fundamental basic content and it should be easy enough. Now, it's been a little bit of time since I was an anatomy student, and I can see from a number who are on the call that many of you were anatomy students at one point as well. And this easy enough thing may not be exactly true. And so for the uninitiated, this is a skeleton, okay? And this is a list or a labeling of many of the bones that we would expect students to learn in undergraduate anatomy. Now, there's about 40 bones here, and for the most part, students are pretty okay with this. Okay? I would have the expectation that I could pick up any one of these bones and hand it to you, and you'd be able to tell me what it is, where it is, and potentially, what it's going to do or participate in. But that's not enough. From there, we want you to be able to identify the specific features on a bone, because if you know the features, you could maybe figure out what passes through it, or what attaches to it, or maybe how a joint is formed. So in my lectures, and this table is taken directly from one of my lectures, we'll talk about some of these features that exist on bones. Now, as you're scanning through this list here, what I hope you're realizing is there's a lot of overlap in terms of the way that some of these terms sound, but also in the features that they kind of describe. So, for example, tuberosity is a large rounded elevation, but a trochanter is a large blunt elevation. I don't know about you, but that sounds pretty similar to me. It sounds pretty similar to a lot of students. And that increases the cognitive load a little bit on them to try and differentiate between these features and then start applying them to bones. And so what this looks like once you start putting it together is something like this. So this is the shoulder blade or the scapula, and I've labeled on here a number of features that we would teach in undergraduate anatomy and physiology. The trick here is that this is now a 3D structure. There is a front, there is a back, and then we can look from the lateral or the outside side. And this is starting to get kind of complicated at this point. There are a lot of terms that perhaps you've never heard before, and there are a lot of bones. Remember, 40-ish bones that we want you to do this for. And so this is where students start to get overwhelmed. And this is where I've been focusing my attention for the last 5-ish years. And the research question that I've been trying to tackle is, well, what makes learning something difficult, specifically in anatomy, and how do we optimize this? And so for the next half an hour or so, I'd like to take you through that 5 years of research. And I'm going to break this into 3 pieces. We'll talk about models and donors and their use in the lab. We're going to talk about digital modalities as they relate to anatomy learning. And then we're going to talk about some instruction methods and modifications that we might make. So kind of going back to the talk title here, models, modalities, and methods/modifications, that's where we're headed. And so the first thing then, drawing you back to this research question of what makes something difficult and how do we optimize it, let's talk about models. So models themselves are a prominent feature in anatomy labs. If you've ever been in an anatomy lab, you notice that there are typically plastic models situated throughout the room, and students can use them as a learning resource. Now, here's an example of what some of those models might look like. We bring them into labs because they are durable. They're made of plastic, so they don't really tear easily. They are lower cost than cadaveric material because you don't really need to maintain them. And if you want more, typically you can purchase or make more very quickly. They can demonstrate some key 3D anatomical relationships. So they take us a step beyond paper or textbook images because we can actually see structures in 3D. Sometimes we can even color code things to help ease the cognitive load. So if you look at this model of the skull over here, we've highlighted the bones in various different colors. Now, a real skull isn't rainbow colored like this one, but you can imagine that this would be useful for a student trying to learn where all these different bones meet up and form joints or sutures throughout the skull. The last piece here is that with recent advances in 3D printing, we can now take some of this work and some of this creation of models into the lab. And in fact, that's exactly what we did. So back around 2017-ish, my colleagues had this idea of printing a pelvis, a 3D printed bony pelvis that they were then going to use to make a new type of model to teach the layers of musculature in that area. So on the screen here, I've pictured Dr. Bruce Wayman, who's my primary research collaborator, and Josh Mitchell, who is our developer within the lab. And as the story has it, I wasn't there, so I'm just recounting from what they have told me, is Bruce said, Josh, we need to print this pelvis. And Josh said, all right, sure, we can print a pelvis. What size do you want it to be? And Bruce was struck in that moment because up until this point, anatomy was just human sized, right? Most often, if we were learning from donors, it's in whatever size the donor was. Or if we're ordering it from a 3D printed company, right, or a 3D model company, it comes in whatever size they made it. And this was really the first opportunity that we started to question, well, what size should we be learning from in the lab? And that gave way to this first study I want to tell you about, which we called the size study, because it focused in on the effect of size in anatomical learning. Now, does size matter? Major question here, does size matter in learning anatomy? If we change the model size, will we see a different outcome? So this study involved 350 undergraduate students with no previous anatomy experience. And we asked them to come in and learn on 2 different models of a given size. So pictured on the right side of the screen is a flow diagram to bring you through what actually happened in that study. But essentially, they were randomized into 2 arms where they were given 2 bones to learn of a specific size, either 50 to 400% size. And then they learned one of them first and were tested on it, then the second one. And then they were given some post-test surveys and some covariates of a mental rotation score and OSPAN, which is a working memory measure. So to give you an idea of what that looked like then, here are the 4 3D printed models that we used. So this is a hemipelvis. Okay. So if you put your hand on your hip, you would be feeling this spot up here above the number 1. This is a scapula or a shoulder blade. This is a sphenoid, which is a bone in the middle of the skull. And this is a vertebra, which is a bone in the spine. So we chose these bones because they were all very different from each other looking, in different locations in the body. And you were assigned to learn 2 of them. And as I said, various sizes. So here is the vertebra shown at 50%, 100%, 200%, and 400% size. To get an idea then of the size coverage that this study ran through, here are the sizes of the longest diameter in centimeters. And so for context, the smallest was the vertebra at 4 centimeters. And here's a picture of our smallest vertebra in my hand. And these are all 3D printed. Okay. And then the pelvis being the largest at about 75, 76 centimeters. Here's Bruce holding that pelvis just for context. So what did we find? So on this graph here, we're showing mean test score on the y-axis and the longest diameter of the model, so model size along the x-axis. And what we're seeing here is a slope here where score increases until you get beyond about 10 centimeters, and then it plateaus. So what we're finding is anything that is greater than 10 centimeters, so data points shown here in the gray area, had no difference in score. So each of these different shapes and colors is paired with a specific bony model, which I've pictured here for your reference. But if we compare the models in this gray area to the models in the white area over here, we see that performance is in fact significantly better in bigger models once they're beyond 10 centimeters. Well, why is that? We conducted a bit of a qualitative study alongside this. And so what we found in doing so is we had participants tell us about their learning experience, and we assigned either a positive or a negative valence to that statement. And so along the y-axis here are the number of participant comments that were generated, and then by model size along the x-axis. So anything in positive is in the green dots here, and anything that is negative is in the red triangles. And what you'll notice here is that in smaller sizes, so everything in this white area, students told us about having difficulty reading the labels and that the structures themselves were difficult to see. And perhaps that factored into why it was difficult to learn on these smaller models. But when we got into the larger sizes, you can see we had this sort of flip in opinion as well, in that they were more difficult to handle, and that sometimes the labels, the 1, 2, 3, that were built into the model, obscured some of the structures because they were so big. So some key takeaways then from this piece is that model size matters up to 10 centimeters. And this is something that is easy to modify now that we can 3D print things. And so we could consider printing really small structures a bit bigger. The other piece is that really large models can be hard to manipulate, but they don't impact performance. So this might represent an opportunity to have some larger scale models in the lab for group work, but them still be useful for students who are wanting to learn independently. The other thing is that label size can influence learning too. We need to consider legibility and obstruction of these labels that we're affixing to models when we bring them into the lab. But of course, like any good study, there are a couple limitations. In this study, model size was predetermined and it wasn't continuous. So students were assigned a specific model size, one of 4 options, okay? And it was only done with physical models. So with that, we have that question about models, but we left with a few more. What about taking this into a virtual reality space and specifically testing in virtual reality or learning in virtual reality? And does giving learners a choice of model size actually matter? So moving into this idea then about modalities, we've conducted several experiments over the last 5 years, trying to get at the role of teaching and learning in digital spaces. And this is because digital assets and virtual reality in education are just exploding. Okay? The use of these adjuncts is on the rise, and up until lately, they've been pretty poorly studied. Developers boast some benefits that it takes learning outside of the classroom. It can put an anatomy atlas and an interactive atlas into your pocket or on your phone, right? And it can decrease the cost of access. We can take this type of anatomy outside of the lab and into spaces where we couldn't previously take wet specimens. So that could be a real benefit. But the question that I've had and my colleagues have had for a while is, well, does it actually work for learning and for testing? So one of the first studies that our group did in this area is affectionately referred to as the Pirate Patch Study. And this happened just before I came to McMaster, but I included it here because I think it lays an important context for the use of VR as a learning tool in anatomy. So in this study, we were interested in figuring out the effect of learning in virtual reality or mixed reality on anatomy performance. So in this study, they employed 140 undergrads, again, with no formal experience, and they had them learn nominal anatomy in 4 different contexts. Okay, so they either learned on a physical model, a plastic model shown here, a VR model, which is an immersive setup, meaning you put on a headset and all you can see is what we've built into the platform here. You see the model and then the fake room that we've built around you. You basically are cut off from the outside world. We gave them an MR, or a mixed reality experience, here with the HoloLens, and this allows you to visualize this model sort of floating in the room that you are physically in. And then there was a key views option. And this allowed students to learn from pictorial images akin to what you would see in a textbook or a lecture. And so we wanted to know, was learning better in one of these 4 environments? So the outcome was a 15-question post-test using a wet specimen, as that's a gold standard in how we would typically assess students in an anatomy and physiology course. So what did they find? Well, off the hop, physical models are best. In this study, performance on tests by those who learned with physical models significantly outranked that on any virtual context or the key views. And so they started to wonder why, in fact, is this? And it turns out for these 3 modalities, physical, virtual reality, and mixed reality, they had the groups, or at least half of the groups, wear a pirate patch. So cover one eye and take you from being able to see in stereo into having monocular vision. And so what they found then was that stereopsis really matters. When you take away stereoptic vision in the physical and the virtual reality model, performance drops. But no such thing happens in mixed reality. Now, the justification that the authors offered here was that in mixed reality, perhaps we're not actually using stereoscopic cues, that the real sense of being able to see an image with 2 eyes. And so we don't see any change in performance when we take that away because it's already not using it. But the use of stereopsis is really important when we're learning in virtual reality, as we see this significant drop, and with physical models. So when it comes to learning in VR, here's what we know so far. Mixed and virtual reality offer significant less learning than physical models. And stereopsis matters. But in this study, a potential limitation is that we saw a mixed teaching and testing environment. We were teaching in the context where we saw poor performance with virtual elements, and we were testing with physical models. And so perhaps that has something to do with it. The other piece, and we've done a scoping review on this, my student Sakshi Sinha completed this one, found that there are a number of determinants that factor into why learning in virtual reality is difficult. One of those pieces is cyber sickness. People get sick, or at least 20 to 30% of people get sick when you put them in immersive VR. Also, we see increased cognitive load associated with learning in VR. But at the same time, students are still pretty interested in it. And with more of a digitally native population of students coming into universities, perhaps these 2 pieces, the cyber sickness and the cognitive load, will decrease over time with more experience in these modalities. So our next piece came to figuring out, well, what happens if we use it for testing? Right? What if we have learning set up like you would in an ordinary classroom, but could we test using VR where we have potentially a shorter exposure period and then be able to move these tests outside of the lab? And so that's exactly what we did next, which with a study that we called the VRBER, or Virtual Reality Bell Ringer Study. So in this study, we tested 51 students, some undergraduate and graduate, on course-specific content using virtual reality, either with a 2D or a 3D setting, and lab specimens. And this, to give you an idea of how we did this, we took models that we had in the lab. So these are all plastic models, and we photographed them using specific specifications to produce a left, a right, and a center image based on the camera location with the model. We then built these models into the app so that if you were given the stereoscopic protocol, you had a left image and a right image delivered to each eye using this cardboard headset and a phone. And if you were in the monoscopic version, you would see the center image sent to both eyes, so you would only see one view of it and not true stereopsis. The outcomes then here were because the students were tested in all three modalities, lab, 3D, and 2D, each on 15 different questions. We looked at the outcomes then of those test scores. We also used the SSQ cyber sickness score to get an idea of the cyber sickness felt by the participants, and we measured their cognitive load using a PASS score. Now, we used an OSPE test here, or an objective structured practical exam. But for those who don't know what that is also another term for a bell ringer, if you've been through an anatomy exam before. And this is a common anatomy assessment method. In this, we ask students to answer questions about a pinned anatomical structure on a model, sometimes an image, or sometimes a cadaveric specimen. And so it would look something like this. You'd come to a station, you'd see a model, and you'd see a pin affixed to it, and we'd ask you a series of questions. Perhaps, what bone is this? For those who recall from earlier, it's a scapula. What's the pinned feature? This is the subscapular fossa. And then maybe what muscle is found here? And the answer to that would be subscapularis. And so students would go through a series of these stations, 15 for each modality, and answer questions, one question per station, though I've demonstrated 3 here. So what did we find here? Well, again, 2D performance lagged significantly behind that of 3D and laboratory, but there was no difference between the 3D and the laboratory performance. This is kind of a big deal because it means I, as an instructor then, could conceivably offer an assessment using a 3D headset and still have students perform the same as if we were actually in the lab. And so that increased flexibility, that accessibility, that could be a real benefit to be able to bring into our classroom. But before, we got all excited about this, we looked at the other pieces. First, there's no correlation between cyber sickness measures and test scores across the modalities. And that's a good thing. But students overall reported high ambient cyber sickness scores. So that means people who were participating in the study were feeling ill. And these were short exposures of about 15 minutes for each test. And that's not great, right? You want students to be able to perform their best on these assessments, and making them feel nauseous and dizzy and get headaches, it just doesn't align with that. The other thing is we identified that cognitive load was significantly higher for the virtual reality tests, so in the 2D and the 3D modalities. So what do we take from this? Stereoscopy is still really important for testing, and that mirrors exactly what we saw in the learning phase. Okay? It's a promising opportunity for testing, especially when we're looking at a 3D virtual reality representation, but there is still some limitations we need to address. We need to consider cyber sickness and what this does for students. And we need to figure out if potentially some of the issue here is how we're presenting these models. Maybe it's a size issue. Maybe the way that we're actually visualizing these models in 3D space or virtual space is not compatible with best learning practices. And the other piece is, what about interactivity? We basically gave students a 3D image to look at. If you ever used those plastic viewfinder toys as a child, where you put the disc in and you looked into it with 2 eyes, that was similar to what we were doing here. And so you couldn't actually interact with the image that you were given. So does that actually matter? So for those kind of keeping score, we've looked into models, we've looked into VR testing and learning, and now we're still kind of wondering, does learner choice matter? And what about this idea of transfer appropriate processing? And this refers back to that idea that if we test in the same modality that we learn in, we should do better than if we have a mismatch between the two, which is what's been done in previous studies. So with these sort of new questions in mind, we moved into our next study called the SEAL study, or the size effect on anatomy learning. And so we went back to this idea of size seems to matter, but what happens if we take it into VR? And then what happens with that testing piece? So in this study, we had 89 undergraduate students. And in terms of the methodology, they were assigned to either a physical modality or a virtual reality modality for learning. And they were asked to choose one of 13 sizes of models to learn from, ranging from 3 centimeters in diameter, all the way, or longest diameter, all the way up to 39 centimeters. So this is what the protocol looked like, and it looks a little bit complicated at first glance, but on the left is your virtual reality setup, and on the right is your physical setup, and so we tried to keep them as similar as possible. So we'd start off with a pretest, and this would give us a baseline information around how much they knew about the vertebra, which we use one model here. We then let students select a size to learn from, and they could pick any one that they wanted. In the virtual system, these would rotate around in a circle, and you got to choose the one you wanted. And in the physical one, you just walked along this line and picked the vertebra of choice. We then gave you 15 minutes to learn 15 structures on the model with a word bank here and a number paired with a number on the actual model. And then we moved into post-testing. And regardless of which system you had learned in, whether it was virtual or physical, we gave you a physical test and a virtual test. And then we looked at the scores across them. So we wanted to look at post-test scores, the model size selected, and any interaction between the modality you learned in, whether it was virtual or physical, and the modality you were tested in, again, physical or virtual. So the first thing we found is that participants choose approximately the same size, whether or not they're in physical or virtual environments. And this was really interesting. Right? This around 25 centimeters is kind of keeping in line with our size study that I told you about earlier, where we found that increase in performance up to 10 centimeters. So this is interesting and additional evidence for upsizing small models. Students both naturally want to choose something a little bit bigger and will perform better if it's over 10 centimeters in longest diameter. We also saw, though, that there was no correlation between size and performance. So unlike the size study, at the 10 centimeter threshold, performance was equivalent in this study. And students self-selected here, so maybe that has something to do with it. The literature shows that self-determination can influence learning outcomes. And so perhaps by giving students this element of choice when it comes to learning, we can combat some of the issues that we saw in that initial study where students were given a small model to learn from. If that was in fact their preference, maybe that's okay. In terms of that transfer appropriate processing piece, what I've got here on the y-axis is actually mislabeled. That is score, not size. So score out of 5. And then on the x-axis here is the learning modality. So this is the virtual modality. This is the physical. And then the tests are grouped here. So if you were taking the virtual test, that's the green bars, and the physical tests are in the orange bars. And there were no differences at all across these 4 groups. So there is no differences in test scores across learning modality, testing modality, or any interaction between the two. So this is really interesting. It means that learning and testing pairings don't seem to influence test results. And this is really great news for those of us looking to use VR at home, and then be able to test using lab-based specimens in a more formal bell ringer. So that's great news for students. And it's even great news for faculty who are looking to train with real specimens in the lab, but then test with a virtual model afterwards. It seems both might be appropriate here, barring in mind some of those cyber sickness issues that we still need to navigate. So takeaways from this then, learning is generally better with physical models than in virtual reality, but this could be changing with time and technology advances, or the differences between the 2 studies that I presented tonight could be to the simplistic testing that occurred in that second study. So we need to do a little bit more work to figure out the type of testing that is appropriate with VR setup. Regardless, if we are going to be testing students, it needs to be done in 3D, whether we're in the virtual or physical environments. And students select similar sizes. And so perhaps this is an opportunity for us to print models based on other practicalities or student preference. And this might be a consideration going forward for someone looking to outfit a lab with new models. The last piece that we learned is that transfer appropriate processing doesn't hold here. Students perform equally well in VR and lab tests, regardless of the training modality. And this is encouraging for learners and teachers alike. So with all of this in mind, we've addressed a number of the questions I've put forth so far. The last one then is, well, what can we change in the classroom perhaps? So we've got some ideas about models. We've got some ideas about a virtual space. Are there things that we could change or modify as instructors to make a difference? So I mentioned earlier that one thing we do as instructors is scaffolding. And I said it provides temporary support to help students learn new concepts or skills. And the goal here is that we want students to establish a firm framework so that they can have foundational knowledge before they build upon that and create a bigger framework to move on from. And one idea that comes from that is I do, we do, you do. And so it's a sort of bringing along of a trainee so that they become self-sufficient with time. Now, scaffolding generally works by decreasing the cognitive load associated with a task. So cognitive load defines all of the mental resources that are required for you to complete a task. And that can be subdivided into 3 pieces. We have intrinsic load, which is associated with the inherent difficulty of that task. We have extrinsic load, which is load that's irrelevant but present. So that could be the fire alarm that's going off while you're trying to study. It's irrelevant, but it's certainly taking some of your attention. And then we have germane load, which is associated with processing the information and holding that in your mind. Now, humans, we know, have a limited short-term memory. Right? We can only hold 7 plus or minus 2 things in our short-term memory. And the way that we learn things over time is that we draw upon our long-term memory to sort of supplement that limited short-term memory resource. So when I'm learning something new, I'm actively engaging with what's in front of me with my short-term memory, but I'm also drawing upon my long-term memory to pull in relevant pieces that are going to help me learn that new thing. And so developing strong understanding of fundamental concepts is useful because we can draw upon greater things in our long-term memory. So this is how scaffolding works. We're going to break down difficult concepts and decrease the cognitive load requirements. We can either do that by dropping down the irrelevant but present load that exists extrinsically, so we can take a complicated environment and make it simple, or we can decrease potentially some of the intrinsic load by focusing in on one aspect instead of the whole thing at once. And by doing this, we're increasing that long-term memory, meaning that the next time we encounter this, we're going to have more resources at our disposal to actually engage in learning. So in terms of this scaffolding in anatomy, scaffolding then works best if we have a target. Well, I showed you this slide earlier on nominal anatomy, and I said that the general assumption is that we think nominal anatomy, we, the global anatomy community, is kind of homogeneously difficult, right? We just say, go learn the bones. And that quickly exhausts students' short-term memory. And so this has kind of been turning around in my head for a while then, is like, well, what options do we have then to actually mess with this system? Well, the 2 options I see is we can modify the models or the modality, right, that we present them in, which is what we've done a lot of research on, or we can modify our methods or teaching practice with things like scaffolding, but we have to have a target if that's going to work. So I want to bring you back to this image here, because I casually mentioned that there were 4 different bones here associated with these 4 shapes. What I didn't draw to your attention here initially were these 4 triangles. Now, these 4 triangles correspond to the scapula, and that looks like a pretty flat line in performance. Like the scapula doesn't follow the same trend as the other 3 bones. And in fact, when we compared the performance on across these these 4 bones, okay, between those that were less than 10 centimeters in the lighter bars, and those were greater 10 centimeters in the darker bars, there was a significant difference in performance for all of the models except for the scapula. And so for years, I have been wondering why this is the case. What is it about the scapula that makes it different to learning? Right? What makes it easier for students to learn the scapula over these other 3? And so I've been kind of racking my brain about it. Maybe it has something to do with symmetry, right? The scapula isn't symmetrical, but neither is the pelvis. Or maybe it has to do with its real anatomical size. It's kind of in the middle. Maybe that has something to do with it. Maybe it has something to do with the origin of the words. But again, most words in anatomy come from either Latin or Greek. So that could be part of it, is just familiarity with the terms. I'm not sure. Maybe it has something to do with complexity. But how do we measure complexity? And maybe it's just more or less difficult. Maybe just the perception of these bones makes them seem more or less difficult to learn. And with those last 2 pieces, this complexity piece and this difficulty piece, we've embarked on a new line of studies, which are actually ongoing right now. And we've called these the class studies. So this is the challenges in learning anatomical structures studies. And our current goal then is to better characterize difficulty in anatomy learning so that we can focus teaching modifications on these areas, that we can provide a target for the scaffolding that we'd like to see happen. So we've got 3 studies that are ongoing and upcoming with the support of funding from Merit. One of them is a scoping review, and we're trying to characterize the association between performance and determinants of learning difficulty. So we're surveying the literature to figure out what people find difficult in terms of anatomy learning, and hope to come away with some clear ideas about where difficulty exists in anatomy and what options we have for modifying that. We're also running a Q methodology study, which is a mixed methods methodology, allowing us to look at both quantitative and qualitative measures of opinions, values, and preferences. So we're surveying, our plan to survey students, teaching assistants, and faculty members to try and compare and contrast their opinions regarding anatomy learning difficulty. And this is to help ensure that the approaches we eventually develop align with both faculty and student perspectives and their needs as stakeholders. And lastly, we're next planning to do a quantitative study where we actually are going to manipulate the way that students interact with the models. And we're going to use the targets we find in the scoping review and the Q methodology study to choose these targets, and then try and develop some of the teaching modifications to evaluate. So to conclude, based on everything I've shared with you tonight, 1, anatomy education works, right? We know that people learn anatomy and have been learning anatomy since, hundreds of years, but it doesn't mean that it can't be better. And with advancing technology around us, we need to be judicious as educators to ensure that what we bring into the classroom is effective, both for learning and teaching. And creative solutions and rethinking the way that we've always done things is the only real way forward when it comes to advances in education. Second, change is complex. Changing the way that we teach requires a thoughtful and multifaceted approach. We need to consider stakeholders, the implications of this work, and potential outcomes. So I spoke earlier about this idea that we want to have a desired level of difficulty. Well, we want to make sure then that we're measuring the impact of these changes so that we're not swinging too far in the too easy or the too difficult realm and actually land in that desired area. And the last thing is that nothing happens without teamwork. So this is a photo of our broader MAC Anatomy group that we brought to the American Association for Anatomy conference last year. And all of the studies that I shared with you today were done in partnership with undergraduate students. And so kind of a shameless plug on that front is that they're the real heroes of this research program. And it's my honor and privilege to be able to work with them and to do such cool research in partnership with students. And so with that, a few thank yous are, of course, to my outstanding student team that make work like this possible. My primary collaborator, Dr. Bruce Wainman, Drs. Nuri Akhtar Dinesh and Jeff Norman, who've collaborated with me from the stats perspective and understanding new methodologies that we could apply. Josh Mitchell for all of his programming and development expertise, Anthony Siracco and Dr. Alexander Ball, who started off on some of the VR work in the early days, and broadly the whole Mac Anatomy community, both for supporting this research for so many years and funding some of the projects that have come out of it. I also want to thank Merit for the opportunity to speak with all of you tonight, and of course for their funding my research program that's currently ongoing. And with that, I'm happy to take any questions that you have. Thanks for your time.
Great. Thank you so much for this awesome presentation. Like I mentioned at the beginning, if you have any questions or even just thoughts and comments, please do leave them in the chat. But if you wanted to speak up, please do use the raising hand function on Zoom so that I can see you and I can give the floor to you for any questions. Maybe as everyone is thinking, I wanted to ask you something. Like, I remember when I was an undergrad, so I did my undergrad in anatomy and cell biology at McGill. And so we had an anatomy lab where we had our anatomy group in a small lab group where we worked together to learn the different anatomical structures and the variations of structures. And based on my understanding, and do please correct me if I'm wrong, but a lot of these studies were done where it was individual learning rather than learning at a group setting. Like, do you think, because in my opinion, I found it to be quite useful to be in that group setting to exchange ideas. And there is, of course, a lot of literature out there that show the potential benefits of that group learning. I just found that anecdotally in anatomy. So can you, like, are you guys doing any studies where, or thinking of any studies where you might want to look at that group learning in the physical models, but also the more virtual environments? And what are your thoughts on that?
Yeah, that's a great question. Thank you for that. So you're right. Most of our studies have been focused on students learning individually. That is really just a practicalities sort of piece and being able to schedule participants to come in to the lab and to learn when they are able to. I think you raise an excellent point, though. You're right. Learning doesn't really happen in isolation, and pulling that piece in is going to be a valuable part moving forward. We have some upcoming studies in another line of research I'm involved with in terms of embalming and surgical skills, and that's going to include going to happen in a group environment. So ideas for those are certainly coming, but you're right. I think that'd be a fantastic next step in this sort of series of work. Thank you for the suggestion.
Thank you. James, I see your hand is up. Please go ahead.
Hey, Danielle, thanks for great presentation and talk. Lot to take away from that. Just notice a lot of your studies themes were with undergrad students and people without previous anatomy knowledge. Have you looked into that with learners that had a little bit more, such as like our surgical foundation residents and junior learners?
Yeah. Thanks, Jimmy. Appreciate it. Nice to see you as well.
Yeah.
So no, we haven't brought this type of a study into that environment yet. The primary reason for it is this is really fundamental concepts that we're trying to kind of start off with. And more senior residents would already have that information. And so testing their ability to learn in that context wouldn't be appropriate in terms of, the target population we're kind of moving towards here. That being said, I think moving in that way and looking at the way that more senior learners are learning and engaging with anatomical material is certainly relevant. So for example, the one study I mentioned there, looking at surgical skills training, is going to use PGME residents and look at how they're learning using donors and more of a skills-based setting as opposed to this foundational content.
Does anyone have any other questions? Please do raise your hand or use the chat function. I do have one more question, Danielle, if it's okay. So obviously this is almost like this is the initial step, like learning anatomy. That's gonna eventually, for a lot of the clinical learner, that's gonna apply to to the real world, like if we just give residents as examples. I was just wondering if you have looked at or have done any studies where you were able to explore that transfer of learning from let's say learning the anatomy in terms of the how it is versus like applying that learned knowledge into something that's a bit more clinical or practical.
Yeah, that's a great question. So as I'm sure many on the call can appreciate, having participants come in at multiple time points makes answering some of those questions kind of tricky, especially because going from a novice learner who is going to find this information, useful and novel, all the way up to a more senior learner who's going to be applying it in a clinical situation takes a pretty large amount of time. So we haven't been able to do that. But in a different study, we are looking at knowledge retention over the duration of a course. So looking at how students are engaging actually with multiple choice testing and how that can promote knowledge durability much beyond that initial post-test. And so it kind of gets at that idea of that I know that initial post-test may not be a reflection of learning and maybe more of recall. And we look at that being as a sort of first step towards learning. But you're right, that longitudinal piece and how this could transfer into clinical applications is certainly an appropriate, avenue to explore more.
Thank you. Lawrence, please go ahead.
Thanks so much, Danielle. Super interesting talk. I'm wondering, as you're running through this and we're hearing about 3D and VR and all of this stuff, I'm wondering how much flexibility in modality is part of an accreditation standard for the anatomy center. Insofar, I'm wondering how much what you're proposing offers solutions to a requirement for your education mandate. Maybe you don't know the answer to that question. I'm assuming the anatomy center has an accreditation requirement.
So the Anatomy Lab itself is governed by the Anatomy Act and is overseen by the Coroner General of Ontario.
Okay.
That sort of series of things kind of governs how the use of cadaveric material kind of exists within this space, and whom is allowed to be in the space and what it's allowed to be used for. So that's all really clearly defined sort of policies, if you will, that actually exist outside of the university and govern the 11 schools of anatomy across Ontario. So that exists there. Your question about virtual reality and virtual anatomy and taking sort of what was potentially once cadaveric and turning it into a digital format, is that what you're?
Yeah, I'm just wondering how does this development interact with that governance and what flexibility does it give you?
Yeah, so the short answer to that is it's tricky. So there is a major discussion happening in anatomy communities across the world, really, around the ethics and the use of donor material and what we are asking donors to provide in terms of consent when it comes to the use of the body and its portrayal in, whatever environment, whether it's research or learning, and whether that can extend from a physical space to a digital space. So there are many new guidelines coming out. I believe the most recent one came out about 4 months ago from the American Association of Anatomy, which is one of the largest societies. It is the largest one in North America. And so those ideas and those sort of concerns around the ethics and the policy piece are certainly coming up in anatomy and have really been sort of thrust into the spotlight with the use of more 3D technology. I can tell you that the governance rules in Canada are much more strict than they are in the US. And so we're starting to see the need for more policy and more development on this stage. At the same time, many of the products that are kind of being used right now are commercially available products. And so they kind of exist in a sense outside of the Anatomy Act as applied to universities and the content, like the physical content that we're entering into a contract with donors and donors' families about. And so that piece I can't really comment on and what their legislature would permit or not permit them to do. But I think from the accessibility standpoint, being able to move outside of the lab could be a really good thing for some learners. Some people find it really challenging to be in that space. And I get it, right? It's a very unique space to be in. And that could get around some of those issues that students feel with discomfort, or could help them transition through that in sort of a more or a less abrupt way. And so I think there's sort of potential on each side and caution on each side, that it's really a major topic right now that we're moving through.
Great. Thank you so much, Danielle. Does anyone have any other questions? If not, I think we can end a couple minutes early. Thank you so much again for your presentation. It was really great to just reflect on some of the things that we have been really seeing in the literature and hearing about it. So thank you again, and I wish everyone a great evening.
Thanks so much, everyone.